Tina Varghese. I am C for today. Thank you all for joining us today, those who gathered here in PIDC and those who joined our Facebook Live. On the occasion of Research, Innovation and Enterprise Open Day, I am very pleased to introduce our esteemed speaker, Dr. Jalison Jacob Cheruvathoor. Dr. Jalison is an accomplished dental professional with a master's in conservative dentistry and endodontics from Vinayaga Missions University, Salem, India. With over 8 years of hands on experience in the field, he specializes in diagnosis and treatment in endodontics and aesthetic dentistry. Currently, he is serving as an assistant professor and head of the Department of Conservative Dentistry and Endodontics at Penang International Dental College, Malaysia. Dr. Jalison is dedicated to delivering exceptional patient care. His extensive research expertise lies in the areas of endodontics and aesthetic dentistry. Without further ado, let's give a warm welcome to our speaker, Dr. Jalison.
Thank you, Dr. Tina. Hi all, good afternoon. Today, my topic is Bioceramics in Endodontics, Advances and Clinical Application. So the expected learning outcomes, understanding bioceramics and their role in endodontics, comprehend the clinical applications of bioceramics in endodontics, recognize the advantages and disadvantages, that is limitations of bioceramics, and explore the emerging advancements in bioceramics. Contents include introduction, classification, historical background and evolution, importance of bioceramics in modern endodontic practice, types of bioceramic materials, clinical applications in endodontics, advantages and limitations. What are bioceramics? Bioceramics are a class of advanced ceramic material used in biomedical applications due to their ability to interact with biological tissues. They are materials that have similar mechanical properties such as hard tissue. They are chemically stable, non-corrosive, and well interact with the organic tissue and help in healing. So bioceramics are introduced or developed as a replacement in human body in terms of joint replacement, bone cementation, and repair or ligament or tendon. Some of the materials used are zirconia, bioactive glass ceramic, bioactive glass ceramic, and hydroxyapatite and calcium phosphate, etc. So bioceramics can be classified into bioinert, bioactive, and biodegradable, depends upon their interaction with the tissues. So bioinert, as it says, it does not interact with the biological system. Basically, it is commonly used in replacements in human body. They will be there for a lifetime. Bioactive, which is commonly used in dentistry and endodontics, they interact well with the tissues and produce tissues as well as help in healing and repair. Some of the materials uses are bioactive glasses, bioactive ceramic, and hydroxyapatite and calcium silicate. Sometimes the bioceramics are also called as calcium silicate cements because the commonly used bioceramics are calcium silicate cements, which is used in bioceramics, and composition is based on ceramics. So it is also called as calcium silicate cement at times. And the third generation is the biodegradable. That is, the name says it's degrade over a period of time, and eventually it is replaced or incorporated into the tissues. So most commonly used in tissue engineering. So historical background and evolution. So bioceramics was introduced in 1993 as a root filling, and over a period of time it has evolved, and it is got approved in 1997 by FDA, and followed by the first commercial product called as ProRoot MTA is come out in 1999. There are a lot of drawbacks initially when it is introduced, something like discoloration can happen, and sometimes it is high cost, and there are several other drawbacks. When later in 2002 there is one more MTA introduced, that is white MTA, which overcame the drawbacks of the previous MTA. and improved setting and setting time, etc., like that. And in during the 2000 and late 2010, there are a lot of materials are introduced into the dentistry and endodontics. Such like one is calcium enriched mixture, which is introduced in 2008, which is something like a calcium compound, have the similar capabilities of MTA. Then later in a dentin substitute called as biodentin is introduced in dentistry, which can form good bonds with dentin. Then later in 2011, a resin-based bioceramic is introduced, that is Theracal, which is commonly used as a liner in pulp capping agents. And there are a lot of materials such as sealers and putties are introduced in today's endodontic practice, and ongoing research is going to improve their efficacy and biocompatibility. Coming to the types of bioceramics. Bioceramics can be classified or categorized in terms of the material availability, composition, and their way of setting procedure. So some of them are ProRoot, MTA, Biodentin, and Bioaggregate. They are powder and liquid combination, which is having the powder composition is tricalcium silicate and dicalcium silicate mostly. And they have a water component. Once it is mixed with the water component, it forms a dicalcium silicate hydrogel, which sets over a period of time as a hard set mask. Then BC putty, that is considered as a root repair material, which is a pre-mixed cement, which can be used also as a root repair material. There are some other materials like Theracal, which I already mentioned. It is a resin-based calcium silicate cement made of type 3 Portland cement, which can be used as a liner for the pulp capping cases. BC sealer and endoseal MTA are paste-based sealers, which is commonly used in obturation along with the gutta percha. And MTA Filpex, BioRoot RCS, Tech BioSealer are commonly used two component paste system or powder system, and it is used along with the gutta percha for the obturation. So these all are the some materials which is commonly used in day-to-day practice of endodontics today, and some have very good biocompatibility, some have some drawbacks like shorter setting time, and some have faster setting time, some have the ability to create a dentin like tissue like hydroxyapatite, or it can bond nicely with the tooth structure. Why it has to be incorporated into the endodontic practice, modern endodontic practice? The reasons are enhanced biocompatibility, superior sealability, bioactivity. That means most of these bioceramics have a good, they all are excellent biocompatible materials. They reduce the inflammatory process occurs during the tissue healing and thereby promote healing with the bioactivity. The tissues interact with the bioceramics and it heals better, and it creates an environment for the tissues to heal in a better way. And they all are having a superior sealing ability. Most of them are fast setting. There are some drawbacks with certain materials which is long acting, a long setting time. So there will be a sealing ability issues, but the recent ones are having a quite good seal ability because of the fast setting reaction. And they have a lot of applications, starts with as a root canal sealer and ends with a root and filling. Then most of the cases they are showing long-term success. MTA is one of the commonly used material which has proven to be have a successful outcome in most of the cases. So clinical application in endodontics. There are certain bioceramic materials which is used as putties and some materials used as a sealer. So the putties are more commonly used as a repair or in terms of pulpotomy. So commonly used for putties are for pulpotomy, then perforation repair, root resorption, root and filling, etc. It goes on. Whereas sealers, it is commonly go ahead with the gutta percha and ability to seal the canals. So one of the application is root canal, and root canal therapy means we deal with the pulpal and periapical diseases of the tooth. So mostly pulpal and periapical disease, it is easy to treat in a root canal treatment and has a very good success with the traditional materials. When it comes with bioceramic sealer, they have a upper hand over the traditional cements. So the procedure as goes on, the infected pulp is removed, and after that, when the canal are sterile, And after the cleaning and shaping, when it is about to obturate, the bioceramic sealers are injected into the canal and it is obturated with a single cone technique. So single cone technique along with the bioceramics have proven to be have satisfactory results based on the current evidence. Here is an example based on the clinical application of bioceramic materials in endodontics. So here is a case study shows that the patient has undergone root canal treatment and after 1 year the lesion is not healing satisfactorily. Over a period of time he developed pain and swelling. After 8 years the patient was referred to a different specialist. The specialist diagnosed with uh, previously treated root canal treated with periapical apical periodontitis and gave an option of either removal and go ahead with the bridge or non-surgical endodontic therapy. And the treatment patient choice was the second one, and the dentist managed to remove the old gutta percha and able to clean the tooth, and it was sealed with a BC sealer, that is the bioceramic sealer, and obturated. And after 1 year, the last picture, you can see that was satisfactory healing. Another study shows the postoperative pain following root canal filling with the bioceramics with the traditional filling technique. And bioceramic sealers was associated with significant long-term, lower short-term postoperative pain with a trend for lower analgesic intake, flare-up, and incidence as compared to the traditional cements. So one of the common reason evidenced for this one is because of their sealing ability when compared to the traditional cements. They can interact with the tissues and the material have a ability to form good bonds with the dentin and thereby achieve a good quality three-dimensional fluid tight seal. So that ingress of bacteria into the root canal is very difficult, and because of the high pH, it creates a environment where bacteria cannot grow. So that could be the possible reason. And there was successful outcome with the bioceramic with single cone obturations with the evidence studies. Next application is root and filling. Root and filling, when it comes, it is orthograde or retrograde filling. So the aim is to achieve a apical seal. So to achieve a good apical seal, the material should have a good biocompatibility, bioactivity, and long-term sealing ability, and promotes healing, tissue healing at the periapical region. So MTA is introduced as a root and filling into the market over a period of time, and it has shown to be a successful one. So rest comparing to the traditional cements, MTA and other bioceramics have been successful, and it is quite well evidenced. Then comes the first application is the orthograde filling. Here the periapex of a root is open or it is not closed properly. So normally in this case, orthograde filling is done with the help of approaching the periapical region through the normal canal, and after the cleaning and shaping, when the canal is indicated for obturation, you have to create a apical barrier at the periapex of the root. So for this commonly used is the bioceramics putty material. Through the orthograde filling purpose means through the coronal surface you insert the material and pack the periapical region and create a apical barrier. Once the apical barrier is created, gutta-percha obturation can be completed with that and complete the procedure. So comparison of microleakage of mineral trioxide aggregate, calcium enriched mixture, cement and biodentine in orthograde apical plate. In this study, biodentine showed promising results and it has good sealing efficacy. So most of the time, the bioceramics have a good sealing ability. As I mentioned before, is it because of the sealing ability with the dentine? They can bond well with the dentine and they can form a hydroxyapatite like structure when in compared to the traditional cements. That could be the reason for the success in this kind of cases. Endodontic microsurgery. This is employed more commonly when there is a persistent infection at the periapical region, which cannot be treated with the non-surgical treatment. So in this treatment, after the obturation is completed, the root is resected at the periapical region with a 3 mm, and after that a cavity is prepared and a bioceramic material is placed to seal the root to achieve a good periapical seal and thereby achieve the success with the treatment. Here also it is something like a root and filling material. Most of the studies have been used MTA as the sealing material, and it has shown good success or successful outcome with the MTA. There are other materials also used for the same purpose, but not much long term studies are there to support the evidence. So the choice of material for this kind of treatment, that means retrograde filling, is MTA. So, in this study, biomaterials in periapical regeneration after microsurgical endodontics, a narrative review. In this one, biomaterials have shown that they have ability to stimulate periapical regeneration, and that is one reason they are used more than the traditional cements. Sorry. Next one comes with the vital pulp therapy. Pulp therapy include pulpotomy and pulp capping. So commonly the pulpotomy we discuss first, that is involving the exposure of pulp due to certain reasons. It can be of caries, or it can be an hydrogenic factor, or it can be due to caries removal. Once the pulp is exposed, or when it is close to the pulp, it has to be sealed with a biocompatible material, and after that it is sealed with a proper restorative material to seal to save the vitality of the tooth, and thereby preserving the function of the pulp. So we have materials like MTA, biodentin, which has the ability to seal the pulpal exposure or close to the pulp, and have the ability to revitalize the tooth or preserve the vitality of the tooth. In such cases, MTA is considered as a better material than biodentin. So it is a case study showing prognostic factor in direct pulp capping with the mineral trioxide aggregate or calcium hydroxide. It is a 2 to 6 year follow-up, and MTAS cap teeth demonstrated a slightly higher success rate than the calcium hydroxide. Another study showing histological evaluation of human pulp response to the direct pulp capping with MTA, calcium matrix mixture cement, and biodentin. And in this study, calcium matrix mixture and MTA is employed as the direct pulping material, has better properties comparing to the biodentin. The reason, even though the biodentin forms good bridge formation and thickness of dentinal bridge, but it is still not considered as better than CEM and MTA. The reason is that in this study, biodentin found lot of inflammatory response comparing to the other two calcium silicate cements. Another comparison of human dental response to calcium hydroxide, biodentin, and direct pulp capping. And based on the study, biodentin can be suggested as the material of choice for the direct pulp capping procedure instead of dical, that is the traditional cement. So most of the time when you look at the pulp capping cases, we have to have a good seal, and one more thing is that we have to preserve the vitality of the tooth. So the compatible material should be placed over there to preserve the vitality. So bioceramics are good candidates for that, and evidence are suggested bioceramics such as MTA and biodentin is a good material to have a successful outcome. Next is pulpotomy. Pulpotomy can be of complete and partial. Pulpotomy means complete coronal pulp, and after that, placement of a biocompatible material on top of it, and it is secured with a permanent restoration. So, biodentin full pulpotomy in matured permanent teeth with irreversible pulpitis and apical periodontitis, a study has done, and use of biodentin in pulpotomy results in success rates similar to that of MTA and reduce the likelihood of discoloration. So, pulpotomy is commonly employed to preserve the vitality of the tooth, but an alternative for the pulpotomy is root canal. So, evidence suggests that there are not many studies supporting the use of pulpotomy with the bioceramics instead of root canal, because long-term studies shows that there is a failure of the pulpotomy and eventually goes for the root canal treatment. Next is regenerative endodontic treatment. So in this regenerative endodontic treatment, there will be a necrotic pulp and inducing of revascularization or a blood clot into the canal, and after that it is sealed with a bioceramic sealer. In this process, the blood clot will induce the pulp stem, and it will regenerate the dental pulp tissue. It will help to improve the growth of the tooth, and the pulp tissue will help you to close the root apex. So this is one of the modality which is alternative for is irreversible pulpitis in endodontics, but success rate for these cases are really low, and there are no indications suggesting that bioceramics help in this process to get the revitalization of the tooth. So, a case study of outcome of revascularization procedures, a retrospective case series, and showed that BC putty and MTA used in regenerative endodontics result in apical healing and maturation in 75% of teeth, which is thought to be as a viable treatment option. But this is a future trend for bioceramics, which has to be shown and proved that it can help in revitalization of the pulp. Next one is perforation repair. We all know that it is a communication, artificial communication between the canal as well as root canal as well as the periodontium. So most of the time, the first thing in the repair of the root perforation is the sealing ability of the material. Traditionally, we use calcium hydroxide, MTA, and other bioceramic materials. So commonly we do here is that most of the time when a perforation occurs, we have to seal the perforation first, then you complete the procedure and finish off the treatment. That depends upon the success rate, how you seal the perforation site. So here is a case study as it is done, and after 1 year, patient developed pain and is referred to a specialist. Once the specialist opened up, he has noticed a perforation on the tooth. After that, it is sealed with a BC putty. And after that, he has continued with the cleaning and shaping. He identified 2 more lateral perforations on the root. Later, when obturation, he has managed to seal the perforation with the sealer, bioceramic sealer, you can see in the picture. And after that, 1 year evaluation, you can see satisfactory healing. So the sealability of 3 different materials to repair furcation perforation using computerized fluid filtration method. And the materials used were MTA and endosequence bioceramic root repair material. All the calcium silicate based materials used in present study showed similar performance in repairing furcation at 24 and 72-hour intervals. So mostly it is because of, again, the sealability of the bioceramics. It has a high mechanism of bonding to the tooth structure, high results can be occurred. And in other way, it has a high pH and it will help in that way to antimicrobial effect, and it helps to heal the periapical tissues better. Then next is root resorption. It is of internal and external resorption. So the internal resorption, there will be loss of tooth structure inside the tooth, a lot of tooth structure inside the canal, and external, it is outside. Sometimes the internal resorption can happen to have a perforation towards the outer surface. So the root canal is complete, root canal is started and the necrose pulp is removed. Once it is indicated for obturation, the part till the internal resorption is obturated with the help of gutta and a periapical sealer, bioceramic sealer. And after that, the internal resorption area is packed with a bioceramic putty and thereby increase the stability of the tooth. And in external resorption, it has to be, after the obturation, the external resorption area has to be exposed and it is packed with a bioceramic putty and closed, and thereby improve the dimensional stability of the or integrity of the tooth. So strengthening effect of bioceramic cement when used to repair stimulated internal resorption cavities in endodontically treated teeth. So endosequence root repair material has provided more strength comparing to the GP sealer technique when both used in resorption cavity. Again, resorption is a rare thing happens with the RCT or endodontically treated tooth. So there are not many cases support the use of bioceramics as a successful outcome. But studies, in vitro studies shows that it can strengthen the root when you use the bioceramics comparing to the sealer, traditional sealer and gutta. So coming to the advantages of bioceramics. So bioceramics have good biocompatibility, bioactivity and sealability and antibacterial properties. So they are excellent with the biocompatibility property, and that helps in healing and promote to reduce inflammation. When the inflammation is reduced automatically because of the bioactivity, the dentine-like structures can be formed over there, or a hydroxyapatite-like structures can be formed over there, and it will be able to seal the cavity properly, and it will help you to promote the healing. And bioceramics, when it gets set, it has a pH of about 10 to 12, and thereby it can provide a good healing environment over the periapical region or when there is the tissues. And it has excellent at handling and adaptability because it is easy to manipulate. Most of the materials are cement or powder, or sometimes nowadays it is available as premix. So it is easy to place into that cavity or the repair area, and it is able to seal properly. And nowadays, comparing to MTA, there are fast setting bioceramics. It can handle properly and it can sit faster, so there will not be much solubility. And one other advantage is that these materials are hydrophilic, so they don't have any problem with contacting with the fluids and dissolution. So there will be minimum shrinkage, as when you use the bioceramics there is no degradation of the material over a period of time. So thereby the sealable material is there for a long time, and it is not going to reduce the apical pack you formed, or stability you have formed. So over a period of time, it is going to give a good result. When it comes to the limitation, one of the main factor is high cost. When bioceramics are introduced in 1993, that is also a drawback during that time. It is high cost. Because of the high cost, it cannot be involved in this normal setup, clinic setting, because the patient has to pay a lot of money for that. And handling challenges. Some of the bioceramics have a longer setting time. Over a period of time, new materials have reduced the setting time, but some of them are still having longer setting time. So over a period of time, when you try to handle it or place into the cavity and modulate it over there, there can be chances of errors, which will cause failures over a period of time. Then comes to the radio opacity. Some bioceramic sealers, such as biodentin, have a lesser radio opacity comparing to the traditional materials. So when in terms of interpretation, or in terms of looking at the treatment, how was it, and how when you interpret and when you look at the treatment, you won't be able to judge the material over there, and it may lead to failure as well. And most of the studies are based on MTA. There are not many studies supporting the new generation of bioceramics. So we need more clinical studies to identify the clinical efficacy of these materials. Coming to the future research and development. Bioceramics have evolved a lot from 1993 to current. But one of the major concern is that they are not a antimicrobial against the bacterial biofilm. Bioceramic as such has a antibacterial effect because of its high pH. So one of the way to increase this one is to adding ions into the bioceramics. Materials like Materials like silver, copper, and zinc is added to the bioceramics in a controlled way, and it is controlled by smart technology so that it can improve the antibacterial activity of bioceramics. Zinc is another material. It can be used as angiogenic and osteogenic and antibacterial efficacy. So it can add it into this one, and it automatically adds to the strength of the cement, mechanical strength of the cement. Another technology is nano integration of the material. Bioceramics strength and penetration and sealability can be increased by adding nano technology. So for this, we have to use the ion doping strategy to improve the sealing ability of the bioceramics. Materials has to be added and improve the proper sealing. Certain materials like biodentin and BC putty have good sealing ability when compared to MTA, but still more improvement is required for better sealing. One of the other method is 3D printing and custom bioceramic scaffold. So bioceramic scaffolds are commonly employed in surgery or surgery. After surgery, when you place it, it can come up with better healing. So a custom made or a tailor made technique with the bioscaffold along with the smart bioceramics can be included into that, so that there will be better healing properties, because bioceramics are known to have a good healing ability when you compare to the traditional cements. And one other area of improvement is that most of the studies are done comparing the products available in the market. Their compounds or molecules are not comparative studies have not done. So we need more research in that area so that we will have a better ceramics in future. To conclude, bioceramics such as MTA have accomplished a excellent bioactivity, biocompatibility, and it is widely used in endodontic practice. However, none of the bioceramic materials is completely ideal. At some point, they have some limitations with their clinical application. With the development of materials such as biodentine and ERRM, they have managed to reduce the setting time and improve the sealing ability of the material. But high quality studies are required with long term follow up, and well controlled laboratory studies are required. And more bioceramics will be come in future with better sealing abilities. These are my references. Thank you.
Okay, then we move on to the question and answer session. So questions are invited from the audience in PIDC and from the Facebook Live as well. So we have one question from the Facebook group.
Considering the advantages of bioceramic, is it possible to use bioceramic as a root canal filling material replacing? Okay. One of the factors we have to consider when do a root canal filling with a bioceramic is that retreatability. Bioceramic is as such is quite hard. So studies have evidence have showed that bioceramic along with single con technique can be employed as a method to obturate, but we couldn't find, I mean, I couldn't find any studies supporting that it can be completely obturated except in cases for internal resorption to strengthen the root other than obturation.
Okay, thank you. Any other question?
Hey, thanks, Dr. Jalison. Just a quick question. A post-endodontic tooth, if it's orthodontically, moved, so there might be iatrogenic root resorption. So what happens to the apical seal, the material, if it stays extruded? And so can you just answer?
Post treated, it's RC treated or not? It's root canal treated. So you are doing the post extrusion you are doing, right? So it is done after the root canal treatment. So I don't think we can do much for that kind of cases. Only thing we can do is that if there is a periapical lesion or something, we can in future introduce the ceramic scaffold, which can be incorporated into that area by surgical method, so that healing will be better. Because bioceramics are known to be used for the healing of bone as well. There are biodegradable materials which can be introduced.
So you could leave it in situ even if
Yes,
the tooth
yes.
has been
It
moved.
will either merge with the tissues or it will be resorbed over a period of time after the tissue healing.
Okay, thank you.
Since you told it is hydrophilic and it is compatible with most of the tissues, can this be used as a furcation defect filler?
Yes, you can use.
Furcation involvement
Yeah, you
defect
can
filler.
use. It is one of the choice of material. MT is most widely used as a sealant for the perforation.
Okay.
And biodentine also have done a lot of studies with that, but long-term success studies are not seen because it is introduced only in 2009. Over a period of time, it has come to the market. It took some time. So we need more long-term studies to prove the success for that biodentine, but MT has good abilities.
Anybody else from audience?
Okay, thank you, Dr. Jalison, for this wonderful presentation. My question to you is, since 1990 to now, so first of all, has the price of these materials come down? Number one. Okay. Number two is, as an academician, what challenges do you see in terms of integrating the use of this in to teach students? Are we using it already, or there are challenges? And if there are, what do you think? How can we actually overcome that?
See, bioceramics as such is quite expensive. That is what normally it says. For example, if you have to buy a bioceramic in Malaysia, it costs around somewhat about 250 to 450 ringgits. and it's a small grams. So that is one thing we have to understand from the expensive side. And apart from that, integrating into the students, we are already using these materials in clinic setup now currently, but students are not able to do it in such a way because it needs little bit of technique. It's just a technique sensitive procedure, so you need little bit of handling properties to make sure that, especially for orthograde filling. When you're doing for a retrograde filling, it is normally like you have the access to the apex and you can place, it's a small cavity, whereas for the orthograde filling you have to pack it through the canal and make sure you create an apical barrier so that the bacteria and byproducts will not enter into the canal. As such, you can use it, there is no software in that, but it needs some handling management, that's all. Yes, we teach.
Okay, anybody else?
Thank you.
Okay.